The Shoulder and Upper Arm Pathologies, Chapter 15. This is a continuation of the lecture from Tuesday, since I will be away at a conference. Today we're going over muscles of the upper arm. The triceps brachii. The triceps brachii originates off the infraglenoid tubercle for the long head, the superior one-half of the posterior surface of the humerus on the lateral head, and inferior two-thirds of the posterior surface of the humerus for the short head. The word triceps, the first three letters, tri, means three. That means we have three heads for the triceps. All three heads of the triceps insert on the olecranon process of the ulna. The nerve for the triceps is the radial nerve. The action is assisting in glenohumeral extension and adduction. The triceps brachii is also the primary mover for elbow extension. The rotator cuff is made up of four muscles. We typically think of this as one muscle, but it's actually four muscles that work together. We use the acronym SITS, S-I-T-S, to define the supraspinatus, infraspinatus, teres minor, and subscapularis. The supraspinatus originates on the supraspinous fossa. It inserts on the superior aspect of the greater tubercle. The nerve is the suprascapular nerve. The action is abduction and external rotation of the glenohumeral joint, and it also functions to stabilize the humeral head. The infraspinatus originates off the infraspinatus fossa. It inserts into the posterior aspect of the greater tubercle. The nerve is also the suprascapular nerve. The infraspinatus actions are external rotation of the glenohumeral head and stabilization of the humeral head. The teres minor. Realize on this slide that the teres minor is the only rotator cuff muscle of these two. The teres major is included here, but it is not part of the rotator cuff. The teres minor originates on the superior two-thirds of the lateral border of the scapula and inserts on the inferior aspect of the greater tubercle. The nerve is the axillary nerve. The teres minor's actions are external rotation of the glenohumeral joint and stabilization of the humeral head, since it's part of the rotator cuff. The teres major, again, is not part of the rotator cuff. It originates off the inferior angle, the lower one-third of the lateral border of the scapula, and inserts on the medial lip of the bicipital groove. The nerve is the lower scapular nerve. The action of the teres major is extension, adduction, and internal rotation of the glenohumeral joint. The subscapularis originates off the subscapular fossa and inserts into the lesser tubercle of the humerus. The nerve is the upper and lower subscapular nerves. The subscapularis actions include internal rotation of the glenohumeral joint and stabilization of the humeral head. If you look at the picture in the lower right-hand corner, you can kind of see the orientation of the four rotator cuff muscles. You can see that the subscapularis is the only muscle that sits on one side of the humeral head. Therefore, it is the only muscle that does internal rotation. The supraspinatus, infraspinatus, and teres minor all do external rotation and sit on the posterior portion of the humeral head. Stabilization of the scapula comes from force coupling. A force couple is defined as muscles pulling in different directions to accomplish the same motion. They all work as a team. To achieve movements of the scapula and the humerus, we often have to activate multiple muscles in order to perform a movement. For example, the upper trapezius, lower trapezius, and serratus anterior all must contract in order to perform shoulder abduction. Other important structures to the shoulder would be the bursa, particularly the subacromial bursa, which sits underneath the subacromial arch. We talked a little bit about the little space that exists for the subacromial arch. So if the subacromial bursa becomes inflamed, there's not much room for things to move. So we may end up with an impingement syndrome or a bursitis from subacromial bursa problem. Our next step is to look at the shoulder evaluation. Taking a history is always important. A good history can help us evaluate an injury before we ever touch the patient. Some important history questions to note for the shoulder. The location of pain. Often pain will radiate from one area to another, or may be coming from another area but present in the shoulder. It's important to ask questions about the pain quality, location, Does it radiate? Does it tingle? And even to have them rank their pain on a scale of 1 to 10. Asking about the mechanism of injury, or MOI. Understanding what forces cause the trauma, whether it's acute or chronic, can help us determine what structures may be injured. Is the shoulder clicking? This could indicate a labrum or possibly the biceps tendon having pathology. Is there a past history of shoulder problems? You'll find in a lot of our patients, a past history of shoulder issues is frequently present. Look for observations. Are there obvious deformities? The pictures on this slide have several obvious deformities, particularly the one in the lower right-hand corner. That's a shoulder dislocation. Look at the level of the shoulders. What is the position of the arm? Is your patient coming in holding the arm or supporting it in another way? Are they stuck in a certain position? With certain labral tears, a patient may not be able to lower their arm, so it looks like they're constantly asking a question. Also looking for muscle atrophy, so a shrinking of the muscle itself. For muscle atrophy, typically there's a neurological involvement. For example, in the picture in the upper right, this is deltoid atrophy. If the nerve to the muscle gets damaged, there's a possibility that that muscle no longer functions, and we get atrophy as a result. Other observations. We're looking for scapular abnormality. Springle's deformity is one such scapular abnormality. This occurs from poorly developed or malformed elevators in the scapula. This is a congenital condition, which means that people have it from birth. This occurs when there's an undescended scapula. Springle's deformity may occur only on one side or in both scapula for a patient. Scapular winging is another condition which we may find. This is a condition in which the scapula protrudes away from the thoracic wall during arm movements. One good way to test for scapular winging is to have our patient push against the wall like they're doing a push-up from the wall. As they push away from the wall, if they have scapular winging, the scapula will come off of the thoracic cavity. Usually it's the medial side, but it may also be the lateral border of the scapula. The picture on the right is a great example of a patient that has scapular winging. We can see that the right scapula protrudes off of the thoracic wall during arm movements. Medial winging is caused by a serratus anterior weakness that's due to the long thoracic nerve being damaged. Lateral winging is less common, but is caused by trapezius or rhomboid weakness due to the accessory nerve or dorsal scapular nerve being damaged. The winging of the scapula may occur as the scapula moves almost into a protracted area. We may also see another version where the scapula is moved to the side. So there may be a rotation or just a lateral movement of the scapulas as they wing. For the palpations, I would highly encourage you to come up with a system, whether that's moving from medial to lateral, superior to inferior, or whatever system makes sense to you. The bony palpation should include the jugular or suprasternal notch, the sternoclavicular joint, the clavicle, acromion process, acromioclavicular joint, coracoid process, humeral head, greater tubercle, lesser tubercle, the bicipital groove, the spine of the scapula, the superior angle of the scapula, the inferior angle of the scapula, and the medial border of the scapula. Soft tissue palpations include the pectoralis major and minor, coracobrachialis, the deltoid, anterior, middle, and posterior, the biceps brachii, both the long and the short head, the rotator cuff, all four muscles, teres major, the rhomboids, both the major and the minor, the levator scapula, trapezius, the upper, the middle, and the lower trapezius, the latissimus dorsi, and the triceps brachii, which again has 3 heads. Special testing, range of motion of the shoulder. We test range of motion of the shoulder using a goniometer. For glenohumeral flexion, normal values for only glenohumeral movement include 0 to 120 degrees of flexion. If there is scapular elevation that occurs, we can move from 0 to 180 degrees. For glenohumeral extension, normal values are from 0 to 60 degrees of extension. The axis of the goniometer should be placed at the acromion process. The stationary arm should be aligned with the mid-trunk, and the movement arm should be aligned with the mid-humerus. As far as glenohumeral abduction and adduction, normal values for abduction with only glenohumeral movement include 0 to 120 degrees of abduction. If there is scapular elevation, we can move through a larger range of motion from 0 to 180 degrees. For glenohumeral adduction, it's usually not measured. This would mean that we are coming across the body, which would include some form of flexion. Normal values that are listed in the textbook are 0 to 35 and even up to 50 degrees if you're looking in certain texts. The axis for the goniometer should be placed at the acromion process. The stationary arm should be parallel to the trunk or to the sternum if you'd rather. The movement arm should go along with the mid-humerus. Glenohumeral external rotation and internal rotation. External rotation of the glenohumeral joint, normal values are anywhere from 0 to 90 or 100 degrees with glenohumeral joint movement only. We have to make sure to stabilize the anterior glenohumeral joint, or patients will start to move their body, which will increase the range of motion. But it isn't true external rotation, so we have to stabilize. Glenohumeral internal rotation. Normal values are from 0 to 90 degrees of internal glenohumeral rotation. The axis of the goniometer should be placed at the olecranon process, right at the elbow. The stationary arm should be perpendicular to the floor. The movement arm should be aligned with the ulnar styloid process. We may have to put a pillow or a roll of towel under the elbow to neutralize the glenohumeral joint. When taking these measurements, we want our patient to be lying supine or prone. The reason why is we want to stabilize the scapula and the trunk, otherwise our patient will develop accessory movements that are not true external rotation and internal rotation. We need to make sure that we're stabilizing. So having our patient seated is not the correct protocol. Glenohumeral horizontal adduction and glenohumeral horizontal abduction. Normal values for horizontal adduction is anywhere from 0 to 120 degrees of horizontal adduction. Normal values for horizontal abduction are 0 to 30 degrees. The axis of rotation for the goniometer should be placed at the acromioclavicular joint. The stationary arm should be positioned parallel with an imaginary line between the acromioclavicular joints, straight through the body, as is demonstrated in the picture. The movement arm should be parallel with the humerus and move with the arm. A good way to determine range of motion, pain, and willingness to move in the shoulder is to perform the Apley's scratch test. We first have our patient touch the opposite shoulder by A, crossing across the chest, B, behind the head, and then C, behind the back. Special testing, manual muscle testing, of the upper trapezius and middle trapezius. For the upper trapezius, we will have our patient sitting. We want to bring the occiput towards the elevated shoulder. We want our face turned in the opposite direction, so it's almost like you're performing a shoulder shrug. As a clinician, we're going to put pressure against the head and shoulder, trying to separate the two to test the upper trapezius for strength and integrity. To test the middle trapezius, we would want our patient lying prone. We would want the arm abducted to 90 degrees with external rotation, or the palm up. We're going to adduct the scapula without elevating it. We would then apply a downward pressure against the forearm and try to have our patient hold that position to test the middle trapezius. The lower trapezius, our patient is also lying prone. The glenohumeral joint is abducted to 45 degrees and the arm is externally rotated. We're going to adduct and depress the scapula. We don't want the patient's shoulders up near their ears. And then we would apply a downward pressure against the forearm. The patient is trying to maintain this position as we are trying to break them out of it. We can test the deltoid as a whole or individually. To test the deltoid as a whole, we want the patient sitting. The glenohumeral joint is abducted to 90 degrees with the elbow flexed, and then we apply a downward pressure to the distal humerus. To test the anterior deltoid individually, we want our patient seated with our glenohumeral joint abducted to 90 degrees with slight horizontal adduction, and the elbow is flexed. We're then going to apply a downward pressure at the distal humerus and have the patient try to hold that position. The posterior deltoid, the patient is sitting. The glenohumeral joint is abducted to 90 degrees with slight horizontal abduction with elbow flexion. We will then apply a downward pressure at the distal humerus while the patient tries to maintain that position. We test the levator scapula and the rhomboids together, although the rhomboids also have another test, which we'll see on the next slide. To test the levator scapula and the rhomboids, we want our patient prone. We want the patient's neck rotated to the testing side, so we're looking at our clinician. You're going to adduct and elevate the scapula. We as a clinician would apply a downward pressure at the scapula and pull the distal humerus out. To test the rhomboids separately from the levator scapula, we would have our patient prone. The glenohumeral joint is abducted to 90 degrees with internal rotation of the arm, which means the palm is down. We want our patient to adduct the scapula without elevating it as we apply a downward pressure against the forearm. The latissimus dorsi is also tested prone. The glenohumeral joint is an extension, adduction, and internal rotation, or palm up. We then apply a downward pressure against the forearm. To test the serratus anterior, we would have our patient supine. We're going to have the glenohumeral joint flexed to 90 degrees, and we will have our patient attempt to punch up as if they're punching in the air. We as a clinician would apply a downward pressure against the fist. The pectoralis minor, the patient is supine. The arms are at the side, and the patient attempts to forwardly thrust the shoulder and raise the shoulder off the table. We as a clinician would then apply a downward pressure against the anterior portion of the shoulder. The pectoralis major has two manual muscle tests, one for the clavicular portion and one for the sternal portion. To test the clavicular portion, the patient is supine. The glenohumeral joint is flexed to 90 degrees. We apply pressure against the horizontal adduction at the forearm. The pectoralis major, to test the sternal portion, the patient is also supine. The glenohumeral joint is flexed to 90 degrees. This time, the patient extends and horizontally adducts obliquely towards the opposite iliac crest, and we apply pressure at the forearm to break them out of this position. The biceps brachii are tested as a group, the long and the short head. The patient is sitting, and the forearm is supinated with the palms up. We apply a pressure to resist against elbow flexion. To test the coracobrachialis, the patient is seated. The elbow is completely flexed and the forearm is supinated with the palm up. The patient is asked to flex and adduct the glenohumeral joint. We apply pressure against the anterior medial aspect of the distal humerus. To test the triceps brachii, we could test the patient in any position. They could be prone, seated, or supine. We're going to apply pressure against elbow extension. This will test all three heads of the triceps at once. For the supraspinatus, one of the muscles of the rotator cuff, the patient is sitting with the glenohumeral joint at 90 degrees of abduction with slight external rotation and horizontal adduction. The elbow should be at 90 degrees of flexion. We want our patient to turn their neck away to help relax the upper trapezius muscle so it can assist. We're going to apply downward pressure against the forearm. The infraspinatus, also one of the rotator cuff muscles, we test the patient in a prone position. The glenohumeral joint and elbow joint are both at 90 degrees, and we apply pressure against external rotation of the glenohumeral joint. The teres minor, one of the rotator cuff muscles as well. The patient is tested in a supine position. The arm is at the patient's side with slight glenohumeral abduction, and elbow flexion to 90 degrees. Pressure is applied against external rotation at the forearm. To test the teres major, the patient is prone, lying on their belly. The patient is asked to rest their hand on the back of their iliac crest. We apply a diagonal pressure on the elbow towards abduction and flexion of the elbow. The fourth rotator cuff muscle is the subscapularis, and remember, it's the only one that does internal rotation. There are two tests for the subscapularis. The lift-off test, the patient is standing or prone. The hand is resting on the iliac crest with the palm up. The patient is asked to lift their hand off of their back. No pressure or light pressure may be applied at the hand. Alternately, we could also do the subscapularis belly press. The patient is positioned in either a standing or supine position with their hand over their belly. The patient is asked to press the belly by performing glenohumeral internal rotation. No pressure is applied by the clinician to test this muscle. Some issues that may occur are humeral fractures. Fractures can occur at the shaft, the proximal, or epiphyseal fractures. Epiphyseal plates are the growth plates. We typically see these in growing children. Typical pain characteristics for a fractured humerus include intense pain, deformity, inability or an unwillingness to move, crepitus, which is crunching, swelling, and ecchymosis, which is discoloration. Other possible findings may include a positive tuning fork test or a positive bump test. We want to check the distal pulse to ensure that blood flow is reaching the distal extremities. We would like to immobilize the patient as soon as possible and treat for shock. We need to activate our emergency action plan and get this person help immediately. If it is an epiphyseal plate, there's a possibility of early closure of the growth plate. This could result in one arm being longer than the other arm, which is a real problem. Here are some different pictures of humeral fractures. The one on the top is a spiral fracture of the humerus. The one in the middle is a proximal humeral head fracture. And the one on the bottom is an epiphyseal plate fracture in a young patient. The fracture at the growth plate may result in early closure of that growth plate, which again is a major issue for young children. We wouldn't want one arm to be longer than another. It creates structural, anatomical, and aesthetic problems for young patients. What does the research say on the tuning fork or the tuning fork with a stethoscope? For just testing fractures of the humerus with a tuning fork, we place a vibrating tuning fork over the distal bone, either the ulna or the radius. A positive sign is pain or even severe pain. There's also an alternative test for tuning fork plus the stethoscope. The stethoscope is then placed on the humerus, and we see if we can hear the tuning fork through the stethoscope. A positive sign is an absent or diminished sound. These tables list what the research says regarding X-ray as a reference, MRI as a reference, bone scan as a reference, or possibly tuning fork or tuning fork plus a stethoscope. We could also use a cell phone plus a stethoscope. In 2014, Matzek et al. Published a pilot study in cadavers, which a cell phone was laid over the lateral epicondyle. The stethoscope was over the anterior shoulder, and a positive sign would be diminished sound. The vibration from a cell phone was used to be listened to through the stethoscope to determine if a fracture had occurred. The bump test is manually producing a vibration. We gently bump the distal bone. Another type of injury may be a clavicular fracture. A clavicular fracture could occur in several ways. It's typically acute onset, which means that it happens rather rapidly. This could occur by falling on the point of the shoulder, sustaining a direct contact blow to the bone, or foosh, falling on an outstretched hand. Typical pain characteristics include pain, deformity, inability or unwillingness to move, crepitus, swelling, and ecchymosis, and other possible findings include a positive bump or tuning fork test. We want to check the distal pulse to ensure that the distal extremities are still receiving blood flow. We can stabilize the individual with a figure-8 clavicular strap, or we can also refer the patient for surgery. Most studies are suggesting that clavicular fractures should be treated surgically to regain the largest range of motion for shoulders. Scapular fractures are extremely rare. They take a huge amount of force to occur. If a scapular fracture is suspected, we also need to suspect a pulmonary injury. This means that the lungs could be injured and the patient may be having trouble breathing. Pain characteristics of a scapular fracture include severe pain, deformity, inability, or an unwillingness to move. Crepitus, swelling, and ecchymosis are frequently present in scapular fractures. Your patient is not likely to want to move very far with a scapular fracture. There are several different types of scapular fractures. When the scapula does sustain enough force to fracture, there are a lot of different parts of the scapula that can actually fracture off. Nearly all scapular fractures will have to be treated surgically. A sternoclavicular joint sprain. This has an acute onset and is characterized by localized pain over the sternoclavicular joint. There may be a visible or palpable displacement of the clavicle. The patient will typically tilt their neck towards the injured side to try to reduce the strain from the muscles pulling on the clavicle. Other possible findings include swelling, ecchymosis may not be present, and crepitus. A posterior sternoclavicular dislocation should be considered a medical emergency. There are potential threats to the subclavian artery, vein, the trachea, the esophagus, and even the lungs if the clavicle moves posteriorly. An acromioclavicular joint sprain, also known as a shoulder separation. The mechanism is typically acute from falling on the acromioclavicular joint. Pain characteristics include localized pain over the acromioclavicular joint and possible displacement of the clavicle depending on the grade. A step deformity is commonly noted with a grade 2 or greater. Other possible findings include pain with glenohumeral abduction and horizontal adduction, a positive Apley's scratch test, they're going to have a decreased range of motion, positive piano key sign, positive AC traction test, and a positive AC compression test. The Rockwood classification of AC joint sprain includes 6 levels, or 6 types. In type 1, the ligament is just stretched and there's no clavicular displacement. Type 2 includes a partial rupture of the acromioclavicular ligaments and possibly may result in a clavicular displacement. A type 6 Rockwood classification for acromioclavicular sprain includes the clavicle going underneath the coracoid process. This is an unusual event in sports. So a step deformity and a piano key sign. In a piano key sign, the clavicle will bob vertically, with the distal clavicle depressing and elevating with manual palpation in much the similar way as piano keys do when we press them down, and when we release, they pop back up. This indicates a coracoclavicular ligament tear. The acromioclavicular traction test, or AC traction test, is one way to test the integrity of the AC ligament. The patient is positioned either in a seated or standing position. The examiner grasps the humerus proximally. The opposite hand of the clinician should gently palpate the acromioclavicular joint as the clinician applies a downward traction on the humerus. A positive sign is pain over the acromioclavicular joint or the presence of a step-off deformity. This could indicate an AC joint sprain. AC compression test. The patient may be seated or standing. The clinician cups their hands over the anterior and posterior acromioclavicular joint. The clinician will squeeze their hands together, creating a shear force across the acromioclavicular joint. The positive sign for the acromioclavicular compression test is pain. This may also indicate an acromioclavicular joint sprain. The cross-body adduction test. The patient is positioned seated, and we passively bring the glenohumeral joint into horizontal adduction to the end of the range of motion and apply a little bit of overpressure. A positive sign is pain over the acromioclavicular joint. This may indicate an AC joint sprain. Pain in the subacromial space may indicate subacromial impingement syndrome, so this test has 2 positive signs. O'Brien's test, or active compression test. There are 2 parts to this test. We have our patient standing. For the first part, A, We actively flex the glenohumeral joint to 90 degrees, and horizontal adduction of the shoulder to 10 degrees, and internal rotation of the arm, so the thumb is placing down. The examiner then applies a downward force to the arm. For step B, or the second part of the test, we use the same position, but this time we externally rotate the arm so the palm is up, and the examiner again applies a downward force. A positive sign for the O'Brien test, or active compression test, is pain in position A, or the first part of the test, and no or decreased pain in position B, or the second part of the test. This may indicate an AC joint sprain or possibly a SLAP lesion. SLAP stands for superior labrum, anterior to posterior lesion, which we'll talk about in a minute. The AC resisted extension test. The patient is seated with active flexion of the glenohumeral joint to 90 degrees, and the elbow is flexed to 90 degrees as well. The patient is asked to horizontally abduct against resistance. A positive sign is pain, which may indicate an AC joint sprain. Unfortunately, to determine AC joint injuries, one test isn't always good enough. Research has indicated that the combination of the cross-body adduction, O'Brien's test, and AC resisted extension test produce the best results to determine AC joint sprain. Glenohumeral instability is another condition that could occur in our patients. We could have instability that occurs in an anterior direction, in a posterior direction, inferiorly, or in multiple planes. Glenohumeral instability could be the result of several issues, including sprains, labral tears, capsular instability, and/or muscle weakness. The anterior apprehension test is a good test to test anterior glenohumeral instability. The preferred position is to have the patient lie supine. We place the patient in 90 degrees of elbow flexion and 90 degrees of shoulder abduction, and we passively externally rotate the shoulder. If we can stabilize the scapula and the thoracic lumbar region, then this test is better. The positive sign is apprehension or unwillingness of the patient to let you move into external rotation. This may indicate that the anterior glenohumeral joint is unstable in the anterior direction. Pain is not a good indicator for the anterior apprehension test. Only apprehension should be considered as a positive test. The anterior apprehension test is only good at testing anterior joint instability. The anterior apprehension test, relocation, and surprise test, or the mean combination. To start the anterior apprehension test, we have passive glenohumeral abduction and external rotation. The patient may complain or be apprehensive and say, ouch. The relocation, if we as a clinician apply a posterior force to the humeral head, the patient will often report that this feels better, and the surprise test is we let go. That is the surprise. So as we let go, the anterior joint capsule is then allowed to go into an unstable position, and the patient may report pain or instability. These three tests, used in conjunction with each other, are actually fairly successful at determining anterior instability of the shoulder. To do an anterior drawer test, we have our patient supine. We're going to abduct the glenohumeral joint 90 to 100 degrees and apply an anterior-posterior force to the humerus. A positive sign is an increased anterior translation compared to the other side. The indication is anterior instability. If we have an anterior drawer test, we probably have a posterior drawer test too. So for the posterior drawer test, we have our patient supine. We abduct the glenohumeral joint 90 to 100 degrees and apply an anterior-posterior force to the humerus. A positive sign is increased posterior translation. This indicates posterior instability of the glenohumeral joint. The posterior apprehension test. The patient is lying supine while we passively flex the glenohumeral joint to 90 degrees and apply a posterior translational force on the elbow, so we push the elbow down towards the table. A positive sign is apprehension and may indicate posterior instability of the glenohumeral joint. To test for a sulcus sign, we have our patient seated. The examiner grasps the elbow with one hand and places the other hand over the acromioclavicular joint. We apply a downward traction to the hand that's on the elbow. A positive sign is the presence of a sulcus. The presence of a sulcus, a little indentation, occurs as the humerus moves away from the acromioclavicular joint. This may be an indication of inferior instability in the glenohumeral joint. Glenohumeral joint sprains and dislocations. The anterior dislocation is the most common. Approximately 90% of all shoulder dislocations occur in the anterior direction. A posterior dislocation only accounts for approximately 3% of all dislocations, and an inferior dislocation is less than 1% of all incidents. The most common mechanism of injury for an anterior glenohumeral joint dislocation is external rotation and abduction of the shoulder. To sustain a posterior dislocation, typically the arm gets pushed back too far and the head of the shoulder pops out of the back of the capsule. An inferior dislocation is usually occurring as a result of hyperabduction. So next week, when we meet again on Tuesday, we will review myology palpations, including the triceps, the rotator cuff, which includes the supraspinatus, infraspinatus, and teres minor and subscapularis, and also the teres major. We'll perform shoulder evaluation or special tests, which include Apley's scratch test, the AC traction test, AC compression test, cross-body adduction test, O'Brien's test, AC resisted extension test, anterior apprehension test, the mean combination, the anterior drawer test, the posterior drawer test, and the posterior apprehension test and sulcus sign, and also perform manual muscle testing on all the muscles listed below. So get ready to do some activity in class. I hope you have a great weekend, and I'll see you again on Tuesday.